Good afternoon, everyone. Welcome to YouTube live sessions from Unacademy. I am your pharmacology educator, Dr. Arpit Agarwal, and today we are going to discuss some clinical scenario based MCQ for the NEET, INICT, or the FMG examinations. The topic that I've chosen today is the autonomic nervous system. Autonomic nervous system. So I hope the audio and the video is clear. So let's start with Unacademy and let's crack it. Let's crack it with me, Dr. Arpit Agarwal, your pharmacology educator. Let's look at some of the very important clinical scenario based questions, the latest pattern of questions that we are seeing in all pre-PG or FMG entrance examination. Okay, so let's start. First question. And these questions are specifically selected from the most important topics and giving you the most important points from those topics. So these are typical questions and highlighting the most important points that will be given to you in any clinical scenario based questions. So question number one. Question number one. A 30-year-old male is brought in unconscious state. Always focus on the age and the sex. He is sweating profusely. So sweating is there, unconsciousness is there. Examination reveals high BP. As you can see, BP is very high, 160 by 90. Heart rate is also high, 100 beats per minute. Bilateral V's, muscle weakness and a constricted pupil. This is our most important clue in the question. He also developed seizure while in the ER emergency room. Most likely diagnosis is. What is the most likely diagnosis? I have already given you the most important clue is the constricted pupil or pinpoint pupil or meiotic pupil. So what is your answer? Opium poisoning, atropine poisoning, carbaryl poisoning or mushroom poisoning? Yes. Let me know. Let me know what is your answer. What is your answer? Opium poisoning, atropine poisoning, carbaryl poisoning, mushroom poisoning. Look at the word constricted pupil or meiotic pupil. Meiotic pupil or pinpoint pupil. Constricted pupil, meiotic pupil, pinpoint pupil. What would you think of? Aditya says B. Aditya says B. B is atropine. Now, Aditya, what happens in atropine poisoning in eye? Can you tell me, Aditya? What is the predominant feature in eye in atropine poisoning? What do you think will happen in eye or in the pupil in anticholinergic atropine poisoning? In atropine poisoning, Aditya, we have mydriasis or dilation of pupil. Dilation of pupil occurs in anticholinergic or mydriatic atropine poisoning. So this is not the answer. Not the answer. Nivita says A. Opium. Opium, Nivita, is a good option which examiner has given. So meiotic pupil. Let's see. Meiotic pupil. What are our important differential diagnosis? Two poisonings are important in meiotic or pinpoint pupil. One is opium poisoning, opium or morphine poisoning, opioid poisoning. So Nivita, you are thinking in correct direction. And another differential diagnosis is anticholinesterase poisoning. Anticholinesterase poisoning, commonly referred to as organophosphorus poisoning. Now, what is the difference? How do we distinguish? How do we distinguish between these two poisonings? You see, you have to look at other symptoms. What are other symptoms? If you have increased secretions given, increased secretions like you have sweating, you have lacrimation, like you have increased bronchial secretion. Very, very important to look for increased bronchial secretion. So if secretions are going up along with meiotic pupil, it is anticholinesterase poisoning. And if you have history of constipation, if you have history of constipation along with shallow breathing, shallow difficulty in breathing or depressed breathing, and insensitivity to pain, insensitivity to pain, you are looking at opium poisoning, morphine poisoning. Remember, morphine causes analgesia, so insensitivity to pain. Morphine causes constipation, so history of constipation. Morphine causes respiratory depression, so shallow breathing. In our question you can see nothing of that sort is given. What is given? What is given? Sweating profusely. He is having wheeze. Wheeze denotes bronchial secretions are high. There is too much fluid in lung. That is why patient is having wheeze. So which kind of poisoning we are looking at in this question? Which kind of poisoning? Let me know. Anticholinesterase or opium? Yes, yes, Maitri. Which we are looking? We are looking at anticholinesterase poisoning. That is the clinical presentation. Meiotic pupil with all secretions going up, anticholinesterase poisoning. Now what is the catch in the question? You see, typical presentation is given. Now coming to this, anticholinesterase poisoning can be of two types, or two types of options can be given: organophosphorus or carbamates, or carbamates. Two things, both are anticholinesterase, organophosphorus, carbamates. Organophosphorus, you can be given the name like parathion, parathion, very good. Malathion, malathion. Now Simran, you are getting. And in carbamate, you can be given names like carbaryl, carbaryl, propoxur, propoxur, used as baygon insecticide. So this is anticholinesterase poisoning we are looking at. So what is the answer now? Answer is C. Answer is C, carbaryl. What is carbaryl? Carbaryl is a type of carbamate insecticide. Carbamate insecticide. So clear? Aditya, Simran, Nivita, Maitri, why this is an anticholinesterase poisoning? Why this is an anticholinesterase poisoning? Because we have meiosis and we have increased secretions. We have increased secretions. What is the confusion here? What is the confusion? Confusion is this BP and heart rate. You see, BP is high. BP is high. Heart rate is high. What do you expect? How can BP or heart rate be high in anticholinesterase poisoning? This is cholinergic poisoning. This is cholinergic poisoning. Increase in acetylcholine is occurring. How can it increase BP? Yes, Simran, that is the confusion. That is why you see I have taken this very, very typical. I have given you the symptom. This, can you tell me? Now you tell me, can increase in acetylcholine, can acetylcholine if increases, can it cause sympathetic stimulation? Tell me, can it cause sympathetic stimulation or not? Remember the receptors of acetylcholine. Remember the receptors of acetylcholine. Can acetylcholine cause sympathetic stimulation? Simran, Maitri, Aditya, Nivita, tell me, can acetylcholine stimulate sympathetic system or not? Answer is yes. How? By acting on nicotinic receptors, sympathetic ganglia, sympathetic ganglia. So that is our next learning from this question. Let us see what is the next learning. You see, you give, this is acetylcholine. This is broken down, metabolized by which enzyme? Anticholinesterase. Remember, anticholinesterase. You give a drug that inhibits this, organophosphorus or carbamate, organophosphorus or carbamate. So acetylcholine will increase in your body, correct? When you give these drugs which inhibit anticholinesterase, acetylcholine will increase in your body. Acetylcholine, remember, can act on two types of receptor. Two types of receptors are there: muscarinic and nicotinic. And nicotinic, one of the type is NN, which is also present on sympathetic and parasympathetic ganglion. So sympathetic ganglionic stimulation can occur via acetylcholine. So that is why BP, I hope you understand, when you give these drugs, acetylcholine increases. Acetylcholine will act on two types of receptor, muscarinic and nicotinic. And nicotinic stimulation can stimulate sympathetic system, and therefore you can have increase in heart rate or BP. So clear? Clear how the BP can be increased, BP can be decreased. BP or heart rate is not the diagnostic criteria in anticholinesterase or organophosphorus poisoning. It can be high or it can be low also. This is the beauty of this particular question. This is the beauty. So what is the learning? What is the learning from this question? If you have a meiotic pupil, you are looking at either increase in secretion or decrease. If increase in secretion, you are looking at anticholinesterase poisoning, no matter what is the BP or heart rate. So that is the beauty of this particular question. Next question related to this. You see, we will do the complete topic. I will tell you the topic in totality using clinical scenario. So the next question says that the patient in previous question was found to be suffering from carbaryl poisoning, which we have diagnosed. Carbaryl. Carbaryl, what is carbaryl? It is a type of carbamate insecticide. Carbamate insecticide, carbaryl. All could be used for treatment except what out of these should not be or cannot be used for treatment of this particular patient. So we have a series of questions. This is the latest pattern of question that we are seeing in AIMS or INICET, also in NEET. So expected in FMG also. Simple question. What is your answer? What is your answer? Simran says C. Maitri says also C. Yes, SN also says C. So that is the correct answer. That is the correct answer. Oxims. Oxims are not used in carbamate poisoning. Not used in carbamate poisoning. So let's come to the treatment of what we call as anticholinesterase poisoning. So that is, first you make the diagnosis. To make the diagnosis, you need symptoms, key symptoms, and then you come to the treatment. So you see, you have a case of anticholinesterase poisoning, whether organophosphorus or carbamate. The drug of choice, I hope everybody knows. Let me know what is the drug of choice. Yes, Nivita, Aditya, what is the drug of choice here in anticholinesterase poisoning? Which drug will you use as drug of choice? Drug of choice for anticholinesterase, organophosphorus, carbamate poisoning. What is the drug of choice? Best drug to treat? Let me know. Let me know in the comment section. Yes. Which is the best drug? Many times this question, every year this question comes. Simple, but every year this question comes. Atropine, says Simran. Anybody else who has a difference of opinion here? Anybody who thinks differently? So atropine is correct. Atropine IV is given. So anticholinesterase poisoning, IV atropine is the drug of choice. Correct. And if after giving lot of atropine, even after lot of atropine, muscle paralysis, if it remains, if, and there is a very big if muscle paralysis remains after giving atropine, you can give oxims. You can give oxims. Oxims are cholinesterase reactivator. So next question, what is oxim role? Oxims are reactivators of cholinesterase. What you need to know in oxim? Very few lines. Oxims are given. Oxims are given in organophosphorus poisoning, but they are contraindicated. They are, yes, Maitri, absolutely correct, Maitri. You are there on the spot. They are contraindicated in carbamate poisoning. They are contraindicated in carbamate poisoning. And Maitri has also already provided us the answer, and so has Simran. Oxims are contraindicated in carbamate poisoning. Why? What is the reason? Because you will say anionic site. Anionic site is not free. Simple. In not free in carbamate poisoning, and oxims bind to anionic site. So simple reason you have to keep in mind, anionic site of the enzyme is not free, which oxims need. Oxims bind to anionic site of the cholinesterase that is not free. So two things are the takeaway from this particular question. Number one, any kind of anticholinesterase poisoning, drug of choice remains as atropine. Drug of choice remains as atropine. When do we use oxims? We use oxims if muscle paralysis continues. Atropine cannot reverse muscle paralysis. So that is the indication of oxim. Question is asked. And in which poisoning oxims are contraindicated? They are contraindicated in carbamate poisoning. So that is the beauty of this particular question. Oxims will not be given. Others, atropine is drug of choice. It will be given. If patient is having seizure, diazepam is the best drug all the time for seizure. And if patient has some unabsorbed substance left, we can use magnesium sulfate as purgative to get it out of his body. So that is about the most important topic as far as the clinical scenarios are concerned from ANS, organophosphorus or anticholinesterase poisoning. Very, very important. And we have discussed both carbamate as well as organophosphorus poisoning and the treatment. Okay. So I hope you are liking this question. Simple but very conceptual question. Simple but very conceptual. Okay. Next question. Now we have a 25-year-old woman. Always I say in clinical question, first of all, highlight the age and the sex. So we have a young woman who comes with difficulty in chewing. Accompanied by vision problem. She has difficulty keeping her eyes open. She has difficulty. Eyes are closing. What will you say this in the more medical terminology? What is the symptom? Difficulty keeping her eyes open. Eyes are getting closed. What is this suffering from? What is this symptom? And complaints of seeing double vision. What is this in medical terminology? Her symptoms worsen as the day progresses. Typical presentation. Symptoms worsen as the day progresses. That means symptoms are mild in the morning. Towards the evening, symptoms are more. Anti-acetylcholine receptor. You see, this is anti-acetylcholine receptor. Radioimmunoassay was positive. What is the meaning? Which test is this? Which is the disease that this test diagnoses? Best drug to start her treatment. Okay. So, yes. So, exactly you have identified. Simran says ptosis. So, you see this symptom. Difficulty keeping her eyes open. Okay, ptosis, drooping of upper eyelid. Ptosis is there. So examiner has given you the symptom in the word of patients. Patient does not say I'm having ptosis. He says I cannot keep my eyes open. Seeing double, diplopia. So what we have? Yes, Reena, hello. I hope you are doing fine. So we have just started. This is the third question of our clinical scenario. You see now the presentation in this particular question. We have a young female. This is very important. Age and sex in clinical scenario based question. Very important. What is she complaining of? She is complaining of ptosis. She is complaining of diplopia. So she has ocular problem. Plus she has difficulty in chewing. So facial muscles are involved. Facial muscles abnormality, difficulty in chewing can be a representative of facial muscle, some problem is there. So these are the symptoms. Further, what is given? Anti-acetylcholinesterase. So the test which has been performed, one by one you have to list the information given in the question. Anti-acetylcholine receptor, anti-acetylcholine receptor assay. So simply what we say when we teach, this is antibody, antibody against nicotinic muscle type receptor, NM receptor is positive, positive. So you see, this is what is given in the question. In this language, it is given anti-acetylcholine receptor. A radioimmunoassay was positive. Radioimmunoassay is used to detect antibodies. So we are basically saying or inferring that antibodies against NM receptor is positive. They are present in the patient. The diagnosis, I think, is very well confirmed. The diagnosis is myasthenia, myasthenia gravis. I hope everybody agrees. Anybody who is not clear? Yes, Reena, are you clear on the diagnosis? Myasthenia gravis, autoimmune disease. Autoimmune disease are common in young females. So that is why the importance of age and sex. All autoimmune diseases are common in young females. Now we come to the drug of choice. What is the drug of choice for this condition? Best drug to start her treatment. Yes, Prague says C. Prague says C. Others, what do you say, Reena? Maitri, Simran, what is the answer? Best drug to start the treatment for this particular patient. Best drug to start the treatment of this particular patient. What do you people say? What should we start? To start the treatment, what should be given? IVIG, corticosteroids, pyridostigmine, mycophenolate mofetil. Autoimmune disease, mostly in autoimmune disease, what kind of treatment do we give? Autoimmune disease, myasthenia gravis. What kind of treatment is given? C, everybody is saying C. So answer is pyridostigmine. That is the best drug, pyridostigmine. Pyridostigmine. Or if not given, you will look for neostigmine. Neostigmine. Both are the best drug to start the treatment. Both are the best drug to start the treatment. Yes, SN. And also Kaushik says A. Kaushik, A is not the best drug to start the treatment. We will start the treatment with a anticholinesterase. Anticholinesterase such as pyrido or neostigmine. Okay. So that is how myasthenia gravis presentation would be given. Again to repeat, age will always be a young female. Always the patient would say young female. Symptoms, ptosis and diplopia will be given. Along with that, there can be other symptoms like this patient has difficulty of the facial or masticatory muscles. Small muscles are involved. So that is why small muscle involvement will be given. Then either adrophonium test will be given or this radioimmunoassay will be given. Treatment will always be pyridostigmine or neostigmine. So these are the characteristic presentation of the myasthenia gravis. Next question. You see, this is a very, very important question. As I told, we will discuss the topic in detail, in completeness. The patient in previous question. So remember the patient in previous question. She was started on pyridostigmine 60 milligram TDS. Okay, that is what we also kind of identified. Few weeks later, she developed severe respiratory difficulty. Severe respiratory difficulty she developed, requiring ventilator support. So few weeks later, she had so much muscle weakness that she was admitted and put on ventilator. Severe respiratory difficulty. Now best drug to produce rapid improvement in her condition. So what we have a case. We have a patient, known case of myasthenia gravis, who is being treated with pyridostigmine. That is what we know. Now this patient comes to emergency with very severe respiratory difficulty and she requires ventilator. First thing, based on this clinical scenario, What is your diagnosis? What is your diagnosis? What has this patient developed to the treatment? So let me know. Let me know. Kaushik, Maitri, Simran, SNSN, Reena, Parag. What is your diagnosis? What has this patient developed? Don't jump to the answer. Try to make, you see, this time treatment has been asked, next time diagnosis may be asked. So you have to first give me what has this patient developed and what we are trying to treat. Respiratory muscle paralysis. SNSN says the correct word, respiratory muscle paralysis, and we call this as the myasthenic crisis. Myasthenic crisis. So what is the take home message from this particular question? Whenever the examiner will ask myasthenic crisis, okay, pyridostigmine, Prabhakar, you have given a very good option that could be true. We'll come to that. Myasthenic crisis, whenever patient examiner wants to ask, he will give history of myasthenia and sudden or severe respiratory difficulty requiring ventilator. This is a typical presentation which has to be given of myasthenic crisis. Prabhakar says that it could also be cholinergic crisis. It could also be cholinergic crisis, meaning thereby we would have given excess dose of pyridostigmine. But you see, this is the standard dose of pyridostigmine. Most of the patients are maintained on 30 to 60 milligram 3 times a day or 4 times a day. So this is not a very high dose, this is a standard dose. And even if there was cholinergic crisis will present with increasing muscle weakness. Increase in symptoms will be reported first. Suddenly respiratory difficulty requiring ventilator will not develop. So patient is suffering from myasthenic crisis. Now we come to the diagnosis. We have done the diagnosis. Treatment. Drug of choice for myasthenic crisis. What is your answer? What is the answer? Simran says E. Anybody? Maitri. What is your answer? What has this patient developed? Prabhakar. This patient has developed myasthenic crisis. What is the best drug to treat myasthenic crisis? Drug of choice for myasthenia gravis is pyridostigmine. But if severe respiratory difficulty develop, what will you give? What will you give? SNSN says A, IVIG. Okay, Maitri also says A. Anybody else who says differently? So answer is IVIG. IVIG, very good. If IVIG is not given, what is the next option that could be possible? Plasma pheresis. Plasma pheresis. Both are equally important and beneficial. But if drug is asked, we will definitely take IVIG. Otherwise, procedure is asked or treatment is asked, plasma pheresis can also be given. Both are equally good in rapid improvement. You see the word rapid improvement will be produced by either IVIG or plasma pheresis. Clear? So this is about myasthenia gravis. How to diagnose? What are the key symptoms? What is the treatment? What is myasthenic crisis? How to diagnose? Which symptom to look for? And what is the treatment? What is the treatment? So next, after anticholinesterase poisoning, the second most important topic in ANS as far as clinical scenario is myasthenia gravis. And I've told you the important points in that. Let's move ahead. Question number 5. This was asked in this year's INICET. Similar, so extremely important question. Prabhakar, thymectomy will never be done in emergency basis. Please remember, thymectomy can never be done in emergency. It will be done only if patient is stabilized. So this patient had ventilatory support need, no thymectomy at this point of time. Next question, it was realized that the patient in previous question was recently started on an antibiotic that worsened her pre-existing myasthenia gravis. So her myasthenia gravis converted into myasthenic crisis, sudden emergency, because the question is saying she was started on some antibiotic. So she was given some antibiotic and post that her condition worsened. Which of the following? Which of the following could be that antibiotic? As I told you, drugs worsening, sudden worsening of myasthenia gravis, drugs causing asked in INICT also. So AIMS level central institutes are asking these questions. Simple questions, but even this most prestigious institutes ask such simple question. So you have to be aware which. SNSN says Cipro. Cipro. Okay. One is option Cipro. SNSN again says Cipro. Look at these: meropenem, ciprofloxacin, gentamicin, penicillin. Anybody else? B. Cipro. Nivita also says Cipro. Pre-existing myasthenic crisis. Myasthenia gravis worsened. Myasthenia gravis. What are you looking for in this question? Please try to understand. Everybody says B. You are looking for myasthenia gravis, which is a neuromuscular disorder. Neuromuscular disorder. Neuromuscular disorder will be worsened by which drugs? Which have neuromuscular blocking action, neuromuscular blocker. So now tell me, out of these, which is the most important neuromuscular blocking ability? Which antibiotic? So if I tell you the mnemonic, would you be able to remember? Latest MCQ, augment your blood pressure. Latest MCQs come in exam, they augment your blood pressure. So latest, which drugs worsen myasthenia gravis? Please remember, local anesthetics like lignocaine. Yes, Maitri, you are on the money, on the spot. M. M stands for macrolide antibiotic. Do we have any macrolide here? Answer is no. We do not have macrolide. Erythromycin can cause it. Magnesium can cause it. C. Curare. Any muscle relaxant, including D-tubocurarine. Any curare-like drugs. Q. Quinine. Do we have quinine, another antibiotic in the option? No, we do not have. Now comes the most important, aminoglycoside. Aminoglycoside worsen myasthenia gravis. Do we have aminoglycoside? We have the answer, gentamicin. Gentamicin. So you see, which drugs worsen myasthenia gravis? Any drugs which have neuromuscular blocking properties. B stands for botulinum toxin, and P stands for penicillamine. So these are the drugs that will worsen myasthenia gravis, because all of them are neuromuscular blocker. So which antibiotic we are looking at? First of all, best answer will be gentamicin. You see, Prabhakar, that is why this is a question asked where? INICT 2020 November. 4 marks in AIMS you get. 4 marks you can get into AIMS, JIPMAR, PGI by solving these kind of questions. Cipro may precipitate myasthenia gravis, but does it have neuromuscular blocking property? You have to understand what question is asking. It worsened myasthenia gravis. If you are given aminoglycoside, that will be the best answer. Best answer out of this is myasthenia gravis. This is the list I have taken from Harrison. You can check the drugs worsening any neuromuscular blocking condition. These are the drugs. So Cipro will be, if gentamicin or other drugs were not given, then you might think of Cipro. Cipro has a different mechanism. Next, a 10-year-old girl was brought for excitation. Again, you see the age, sex, age. We have now a child, excitation, delirium, hallucination. Very important symptoms. They should ring a bell in your mind. After ingestion of unknown substance, actually the question is over. You should be able to tell me the answer. Child with all these symptoms. But still, vitals are temperature is 38.2, heart rate is 150, respiratory rate is 25, BP is 104. Mouth was dry, pupil widely dilated, dilated pupil, pupil dilated and not reactive to light, best treatment. So we have a child presenting with, I would say, important symptoms, delirium. Child is presenting with delirium. Temperature, look at the temperature. She is having high grade fever, tachycardia, dry mouth. I think the diagnosis should be very simple. Dry mouth and dilated pupil. Dilated pupil. Also, please remember, after dilated, they have given non-reactive to light, NRL. What is the diagnosis? What is the diagnosis? Best treatment is asked, but first of all, tell me, what is your diagnosis? As a clinical physician, what is your diagnosis? Simran says atropine. Is that the diagnosis or the answer? I am asking, what has this child developed? First of all, give me the diagnosis. So this is, yes, unknown substance she has ingested. So most likely the girl has ingested datura. So we can say this is datura or same symptom, atropine poisoning. Atropine poisoning. So what are the principal features or anticholinergic poisoning? Anticholinergic poisoning is there. Anticholinergic, always focus on dryness, dry eye, dry mouth, dry skin, dryness. Hyperthermia, temperature going up, and children are very sensitive to hyperthermia. And a high dose delirium. Along with delirium, hallucinations can be seen. Delirium, hallucination. Child may hear voices that somebody is running after to kill him. He may see things, auditory, visual hallucination. So delirium, hyperthermia, and dryness. These are the principal features, along with if you are given dilated of pupil. Answer is, diagnosis is very clear, datura or atropine poisoning. Best treatment, drug of choice for this. Drug of choice, please remember, for atropine poisoning, physostigmine. Physostigmine. 9 Ds of datura, yes. So in clinical question, we are trying to remember the key features. Key features. We have physostigmine, cholinergic drug. Physostigmine as the answer. Physostigmine as the answer. Physostigmine. So that is. So in this question, what we have understood, that in ANS, same kind of options can be given in another poisoning, that is organophosphorus poisoning. Here, there you will have meiotic pupil. Here you have dilated pupil. So it is very important to be aware what is atropine poisoning and what is organophosphorus or anticholinergic. The moment you read dryness and you read hyperthermia, think of datura or atropine poisoning. That is the key symptom, especially in a child. Very important symptom. Next question. I hope you are finding the questions relevant, to the point, and informative. I hope you are finding that your time is well utilized. Okay. So I have specifically prepared these questions with key clinical points, highlighting the key points in clinical presentation. If examiner does not give this presentation, he cannot form a question on these topics. These are the principal main symptoms which have to be given. Next question. A 30-year-old woman comes to you 2 days before she plans to go on a road trip. Age 6. She wants to go on a road trip. Nowadays, this is the fashion. This is the in thing. Going on vacation, road trip. Which movie does it remind you of? Which movie did you saw recently having road trips with friends? You advise transdermal, transdermal scopolamine, also known as hyoscine. Hyoscine. Hyoscine, we all know, is drug of choice for both treatment as well as prophylaxis of motion sickness. So that is what the doctor has correctly prescribed. Transdermal patch can be given for prophylaxis of motion sickness. History of which disease would make scopolamine contraindicated? Which disease, if present in the patient, you will not give hyoscine? That is what the question is asking. So what information or history you should ask from the patient before prescribing hyoscine? Karthik is the new addition to our viewers. Welcome, Karthik. And Karthik says A, glaucoma. Anyway, Simran also says A. Prabhakar also says A. Pankaj says C, cheese reaction. Anybody who agrees with cheese reaction, or anybody who has other option, SN also says glaucoma. So you see what we need to understand here. What we need to understand first of all, that hyoscine is an anticholinergic drug. Anticholinergic drug, number one. So question is basically asking contraindications of anticholinergic. Intraindications of anticholinergic. Now you see, first contraindication or first situation where anticholinergic should be used with caution is history of glaucoma. History of glaucoma. Very, very important. Why? Why anticholinergics are avoided in history of glaucoma? Try to understand that any anticholinergic in eye will produce mydriasis. That all of you should know. Mydriasis. Anticholinergics produce mydriasis, and mydriasis can precipitate attack of glaucoma. Whenever there is mydriasis, pressure in eye increases. Whenever there is mydriasis, the intraocular pressure tends to increase. Okay, so that is why any anticholinergic having mydriatic property is avoided in patients of glaucoma, and that is the answer. Second, anticholinergic if glaucoma was not given. Suppose, what else could have been the answer? History of urinary retention. History of urine retention would also make anticholinergic contraindicated, because anticholinergics relax bladder and cause further urinary retention. So whenever you are asked contraindication of anticholinergics, you have to remember at least glaucoma history and urinary retention. There is nothing of cheese reaction here. Hyoscine has got nothing to do with cheese reaction. Next, we have a 12-year-old. Again, age, sex. 12-year-old. Age is given, sex is not given here. Fever, sore throat, and cervical lymphadenopathy. That means she was a girl, diagnosed with streptococcal pharyngitis and given penicillin. So far we have given that patient was given penicillin. Within minutes she is dyspnea, wheeze. So patient is having dyspnea, wheeze. What does it might indicate? Bronchoconstriction, hypotension. Second thing patient has developed is fall in BP immediately after giving penicillin. After receiving penicillin, she has developed best treatment. Everybody should be aware. This is nothing but what is our diagnosis? As I have been telling, focus on diagnosis first. Write the diagnosis. This is anaphylaxis. She has developed anaphylaxis. So number one, whenever there is anaphylaxis question, the examiner will give bronchoconstriction and fall in BP. Drug of choice for anaphylaxis. Drug of choice. Everybody saying C. Adrenaline is the drug of choice. Intramuscular is the route. Intramuscular is the preferred route. So IM is what we are looking at, and concentration is 1:1000. This is the concentration. So 1:1000. Option number C. Option number C. Now you tell me, adrenaline IV 1:10,000. 1:10,000. Where it is given? Drug of choice in what? 10,000. Answer here is C. This is the drug of choice. IM 1:1000 anaphylactic shock. Where is adrenaline IV 1:10,000 given? Tell me. Tell me where it is given. In which condition? Which condition? You will give adrenaline IV 1:10,000. Where do you give adrenaline IV 1:10,000? Yes. All of you, yes. Where do you give? Cardiac arrest. Simran, not in anaphylactic. We give this in cardiac arrest. Cardiac arrest. So anaphylaxis. Anaphylaxis is asked. Best route IM. Clear, no doubt. So IM. What is the concentration? 1:1000. 1:1000. This is the answer. No doubt about it. If cardiac arrest is asked, IV. And what is the concentration? 1:10,000. 10,000. 10,000. So what we have learned in this question, that despite studying many times, we tend to get confused when such options are given, and we can commit silly mistake. Silly mistake is bound to happen, so we have to be prepared. What to look? First look the route. Remove the options with the non-preferred route. Then look at the concentration. Okay. So what we have learned in today's lesson, we have learned the clinical scenario based question, organophosphorus poisoning, or also you can say versus. We have also seen carbamate poisoning. What is the difference in the treatment? We saw the difference in the treatment. Oxims make the difference in the treatment. Otherwise symptoms are same. We saw myasthenia gravis versus what? We also saw myasthenic crisis. Myasthenic crisis. What is the difference in presentation and difference in drug of choice? Then atropine poisoning, when pupil is constricted, when pupil is dilated. Glaucoma, which drugs can precipitate glaucoma? We discussed that glaucoma can be precipitated by any drug causing mydriasis. Any drug causing mydriasis will precipitate glaucoma. In anaphylaxis, we try to understand what is the difference in treatment with anaphylaxis and cardiac arrest. Cardiac arrest. So 5 topics we discussed in the form of questions and the corresponding difficulties or confusing. So in total, we have done 10 topics trying to understand the topics in detail. So this is the clinical scenario based question session for you. This is the part 1. We have 8 such sessions planned from each topic. So do join me at 7 p.m. tonight. 7 p.m. tonight. At 7 p.m. again on YouTube for more clinical scenario based question from CVS now. CVS we will do at 7 p.m. 7 p.m. we'll do CVS, and tomorrow you can see schedule for tomorrow, and then we will continue the series, 8-part series in the next year also. Next year also we will focus on simple, basic, conceptual question highlighting the most important points. So I hope, if patient of anaphylactic does not respond, yes Simran, if patient does not respond to anaphylactic IM, then we can give IV, and IV will be given 1:10,000. 1:10,000. You are correct. Thunderbolt, hello. But I'm sorry, Thunderbolt, you've joined a bit late. We are already at the end of our today's session. I have given you the links or the timings of upcoming sessions. So I hope you found this session useful, and you will be joining me at 7 p.m. tonight for more clinical scenario based questions from CVS. So thank you all for joining. Provide your valuable feedback in form of your comments. Comment on the video, ask your queries, and do not forget to subscribe to the Unacademy YouTube channel. So this is Dr. Arpit saying thank you for joining and hope to see you again for the remaining sessions at these time points. Thank you.